We do have a quorum now. We have two bills on the agenda. We have I'm going to call it the hemp bill. This HB 1077 is the Medicaid expansion bill. We're going to hear the other one first. It's 1322. We did prepare a committee sub I've discussed with Representative Cannon. He had come with some suggested changes at the behest of the Ag Department. Yesterday, I have implemented their requested changes in the bill. There was also a proposed amendment from Senator Kirkpatrick that expanded the THC isomers that this would apply to beyond Delta 9 to include Delta 8, Delta 10, and Delta 11. All of those are THC containing compounds or isomers. I don't know the science as well as Dr. Raduca and some of the others in the room might, but it just broadens the limitations on the amount of THC to include those as well. It also, at a late ad from the Ag Department, included a limitation on the amount of THC per serving or per package. It's kind of a compromise. There'll be no more than 10 milligrams per serving or 100 milligrams per package of THC in these products. We left off the other day with testimony from the hemp industry, and if I could get you back, JD, to take the podium. I'm sorry, y'all look, you got a beard like his. I thought that was you. All right, introduce yourself again and let me walk through this with you.
Yes, sir. My name is J.D. McCormick, and I'm the chairman and president of the American Healthy Alternatives Association.
All right, and tell me about that organization. Who do you represent?
So our association represents, all members of the supply chain in the hemp industry, everyone from farmers, manufacturers, distributors, and retailers across the United States.
Okay. So yesterday, the Ag Department basically stayed neutral on whether or not we should include Delta 8, Delta 10, and Delta 11 along with Delta 9 as the THC compounds. What is the appropriate term for those? Is it isomer? I don't know the medicine.
Isomer is the correct term for individual constituents or individual compounds found that have a similar chemical makeup or atomic weight. So Delta 8 THC, Delta 9 THC, Delta 10 THC are all isomers or variations of THC.
All right. And so in our proposed committee sub, which amends the original bill, we add all four of those isomers rather than just Delta 9, correct?
Yes, sir. In the version I was just looking at, that appears to be the case.
Okay, if you want to look at page 5 is where that goes in, starting at lines 82.
Okay.
Page 5, we're on the committee sub.
Got it.
Page 5, lines 82, that section on the definitions of THC, it tries to capture all of those known isomers.
Yep, I'm looking at it.
Okay. And am I right that mimics the language that's being used in Tennessee and North Carolina and that is proposed in South Carolina?
It's similar in concept, but it appears to put them up underneath the definition of THC rather than a sub-definition for, say, consumable hemp products.
Right. That's why we just have it in a different section, but the same treatment of those to measure the content that's in any of these consumable products.
Similar in concept, but this seems to apply the 0.3% dry weight basis measurement to all of these independent isomers.
Okay, thank you. And when you guys met in Tennessee creating that bill, did you have the DEA, the FBI, the hemp industry, the Ag Department, everybody kind of
Yes, sir.
put your brains together on it?
In lengthy negotiations and discussions with the Tennessee Bureau of Investigation, the Sheriff's Association, leadership, bill sponsors, and industry members, we were able to, what we believe is strike a balance between industry viability and consumer protections. The idea is to limit, bad actors in the industry, cartoons, things that may be appealing to children, limiting some of the milligram contents per serving, while still preserving, products for people that really do need them.
this bill also followed the Tennessee model in limiting the milligrams per serving. Do you think 10 milligrams per serving is a reasonable limitation?
It's in its current draft form. I don't love the way the language interplays. I think the definitions are a little bit complicated, but yes, a milligram per serving limit of 10 milligrams to 25 milligrams, I think is striking a pretty good balance.
Okay, and we're looking at page 9 for committee members, lines 175 to 182. So do you think 100 milligrams per container or 10 milligram servings is a reasonable limitation for your industry?
I think our membership, especially our manufacturers, may have a little bit of heartburn with 100 milligrams per package, as that's only going to create more packaging. So if a consumer wanted to buy 500, 1,000, 1,500 milligrams for, say, a month's supply, they're just going to have to buy several individual packages.
Okay.
So it's kind of like the Costco argument. If you want to buy a bag of cheese puffs, that's great, but if you go to Costco, you can get a great big bag of cheese
Right.
puffs. So
So the Georgia Department of Agriculture's weighed in on this, and they had suggested 150 milligrams maximum per package. Does that change your calculus or not?
yeah,
I'm
so
not wedded to this amount, but everybody's made concerns about children getting these or whatever, and so, you know, it's additive. The more gummies you eat, you get the same thing. You might as well have, 10 milligrams of THC in it if you're going to eat 10 of these things, right?
Sure. So I understand in concept, and definitely, again, I think the industry has a perception issue, but I think the reality is somewhere between, if we were going to look at a package limit, 1,000 milligrams or more even, I think a package limit doesn't really get to the root of the problem. I think the root of the problem here is testing standards, is marketing standards, is several of the other things that are considered in here. But in the current definition and the way they're kind of bunched together with THC instead of their own independent definition, now you've got restrictions on several product categories that I think might have unintended consequences. So these package limits kind of just, take a sledgehammer to the industry.
All righty. Would you be more comfortable if we increased the milligrams per package or per container to 150?
I don't think so. I still think that doesn't quite get there.
Okay.
I think there's going to have to be some other language adjustments to really get it to a point where I think that a package limit could be workable. It's just there are several product categories, not just edibles, and even in that category there are several variations, tinctures, gummies, and other various forms, where a package limit really does harm the industry kind of at all.
So you're at opposition with the Georgia Department of Agriculture, which you want to control this and their desire to limit it?
No, I certainly wouldn't say we're in opposition. I think it's the way the language is crafted, how that THC definition, instead of a subgroup and subcategory, kind of splits them and then puts them all together with very strict limitations.
Okay.
And
All right,
Yeah.
thank you.
absolutely.
Senator Kirkpatrick, I'm calling you to explain your concerns here.
Thank you, Mr. Chair. I didn't wear my lab coat or my stethoscope today.
Do you have a copy of the committee sub?
I do.
All right, so I want you to talk to us, since it's your sort of workmanship here on page 5, the definition of THC, starting at lines 82. This incorporates the language you have requested. Would you explain to the committee why you want that language and how that helps?
Yes, sir. Well, as a physician, I've always been public safety advocate, patient safety advocate, and we all know now that a loophole in the federal farm bill allows psychotropic cannabis products to be sold across the U.S. by legalizing hemp. With low concentrations of delta-9 THC and high concentrations of CBD. It also contains a number of other cannabinoids which were recently felt to be present in amounts small enough to not produce psychotropic effects. So, as you also know, any cannabis-derived product containing a THC level of greater than 0.3% is marijuana, and hemp is less than 0.3%. So manufacturers can synthesize and sell hemp-derived cannabis products with psychotropic doses of cannabinoids, such as Delta-8, Delta-10, et cetera, by adding solvents and acids to CBD. These products produce similar psychotropic effects, depending on the dose, as we've heard already, as Delta-9 THC, and are sold as consumable hemp products like gummies and so on. And this is not the same as medical marijuana or recreational marijuana. That's a whole different subject. There's currently no regulation of these products, although there are several bills pending, as you know. None of the current bills incorporate anything other than Delta-9 until this substitute, which tracks the amendment that I presented whenever it was, a couple days ago. The FDA sent a number of warning letters to companies that produce these products due to adverse effects for people, especially children and animals. These effects include respiratory depression, seizures, and even death. Although the FDA has the authority to make rules, they want guidance from Congress. The DEA in 2020 clarified that Delta-8 and other cannabinoids that are synthetically derived are Schedule I controlled substances. Meanwhile, poison control centers continue to get thousands of reports related to ingestion of Delta-8 products, over 80% among kids. Some have required hospital admission. It would be very simple, as we're in the process of developing guardrails around Delta-9 hemp products to incorporate the other cannabinoids that are currently being sold. That was the reason for my proposed amendment, and I agree with the language in the substitute bill. This is not a ban. Just want to be clear to that. We just want the public to be safe.
Questions for Senator Kirkpatrick? All right.
Thank you.
I had a number of other people signed up to speak, and we're going to have limited time today, so I'm going to call just a few to be heard, and then we'll take action on this bill. Christina Flores, am I pronouncing that right?
You got it right.
All right, if you'll take, you were here yesterday, I wanted to make sure you got heard.
Thank you. All right, esteemed members of the committee, thank you so much for your time today. So I just was able to look over the substitutions, and while I had something else to say, I'm deeply concerned about the substitutions. While there were already some unintended consequences for business owners, farmers, and medical patients, we've now lumped in several categories, and I'd like to say exactly what was said earlier. This takes a sledgehammer to the industry. We really want to be mindful of this language and really look at the packaging limits. I believe that if we put this bill through, we are going to greatly put Georgia behind when it comes to hemp business. We are all for sensible policy. I am a mother myself. I don't want my child eating gummies, but that's also something that I take care of at home. We need to make sure that education is happening in the home, the same way we require education for alcohol consumption in our home. It's on the parents to ensure that we are taking care of our children and keeping them safe. So I say that it is very important that we look at the language in this bill again before we pass it through. I completely oppose it. It is not ready to go to the public. There are too many unintended consequences.
So it seems like you're saying your industry doesn't survive unless you can sell these products that have more than 0.3% of THC.
No, that's not what I'm saying at all.
You're wanting to be able to sell the Delta-8, Delta-10, Delta-11 to get around the Delta-9 ban?
Let me be clear. I actually don't sell products. I represent patients. I'm a patient advocate, and so I'm. And
this
also,
isn't the medical marijuana we're talking about today. This is the hemp consumables.
yes.
Okay.
Well, I do want to be clear that I do not sell them, but I do represent several people within my community who do sell them and have taken great issue with this. We want to make sure that we are selling safe products on the market, but not restricting so heavily what is happening here. I think that we need more experts on this bill. It is not ready to go, and I urge that we do not vote yes on this bill today.
Should we continue to allow the sale of these hemp products then until we figure it out? Or should we just ban the sale till we can find some
I absolutely
comfortable
don't
levels that we can protect the safety of our children and
I
adults?
absolutely don't think that we should ban the sale. I think that it works in opposition to what we're even trying to do here. We want a thriving hemp market. Business is very important in Georgia. We need to get it right, but we don't need to be extreme in our attempt.
Okay. When the original sort of Farm Act came along and allowed hemp, there was all this emphasis on rope and clothing and everything else. It seems to me that the only viable hemp industry right now is to make consumable products that contain THC.
I think that is inaccurate. There are several apparel brands that rely on hemp to create sustainable. Environmentalists are very hell-bent on hemp products. So I would say that that's an inaccuracy. This is a growing and thriving market, and it could be growing and thriving here in Georgia as well. But it is inaccurate to say that we aren't using it for apparel and other.
So it can be thriving and growing here as long as we allow Delta 8, Delta 10, and Delta 11 in the products?
Yes, and I believe that it is
So
important.
THC containing isomers.
THC, I think, is a very important part of the whole plant medicine. And I know that we have two different categories here in Georgia of medical marijuana and hemp-derived Delta-8 products. But we need to know that THC is a healing element. So it is not just people purchasing it to get high or to use it for recreational purposes. It is also used medicinally. It is sold here in Georgia.
Yeah, I
and
know
has,
we got a whole commission that handles that.
Yes,
from the
so I
medical
just want to make
aspects.
sure, because we are lumping so many categories into one bill, we're now crossing territories, and we need to slow down, have a conversation, and be clear on these categories.
Okay, thank you. Catherine Russell from the Department of Agriculture. No, it's mine and Kay's and the guy from the industry and the agri, all combined.
Good morning,
Good
committee
morning,
members. Good to see you all again. So we are grateful that this committee sub introduces or incorporates some of the changes that we were interested in having. But I actually have some concerns with the way that some of the other changes were introduced. Particularly, we now have an expansion of what THC means, which includes Delta 8 and 10 and whatnot. Those changes were not incorporated into the rest of the bill, where we only look at Delta 9, because that's the only thing that's been outlawed so far. So essentially, there'll be no enforcement mechanism to actually address the new forms of THC that we're recognizing. I probably also would have
Does
recommended.
this give us, you guys, that enforcement mechanism there? I mean, this just folds it into
It
yours.
doesn't. We need to make some changes.
What, you need more enforcement powers?
No, we need to remove the restriction to Delta 9 THC, and it needs to just say THC, if that's the intent.
Okay. And in our committee sub here, it just defines THC to include Delta 8, 9, 10, and 11. I was asking you yesterday what was the Ag Department's position on that, and you said that's a policy decision. We
That's
can
right.
handle it if y'all decide you want to
Right.
capture all the THC components or isomers or not.
That's correct.
Okay.
I agree with that.
And I put the packaging levels in there at your request. I mean, your personal request, you wanted 10 milligrams per serving and 150 milligrams per package.
I'm afraid I don't remember that conversation, Mr. Chairman.
Okay. I need to talk to the legislative council. That's where I got it from. I thought they had an email from you. Maybe it came from somebody else.
I think it may have.
Okay.
I actually probably would have, I do have language for that. I probably would have structured it a little bit differently.
How would you do that? How many milligrams per serving would
Well,
you think is safe
I
for
think-
Georgians?
10 is fine, right?
Okay.
It's when we look at the total container.
How much do you think would be appropriate for a total container?
Well, you can do it at 100, but what's important here is that you have to separate out, you have to address the fact that you could have 10 gummies in a jar, or you could have one giant gummy
Yeah.
that's supposed to contain 10 servings, and it's not, they aren't separated. There's no indication that these are separate servings. I think that
It's safer for them to be separate servings, right? Okay.
and I actually have drafted some language that specifically addresses that.
What would you prefer it to say? If we
Well-
were to take your language, how would it read on the limitations in milligrams per serving and per package?
I don't have it in front of me. And I don't want to misspeak because, words matter, but we would address the total percentage that could be included. We would address total milligrams per serving. We would address total milligrams per container.
All right, let's
which-
just talk about those two issues for
Okay.
now. How many would you want to limit it to per serving?
I think the standard is about 10 milligrams.
All right, and how many
across-
milligrams would you like to restrain it to per package?
I
If they're 10 milligram servings, how many servings do you want us to allow in a package?
I think 15 would be okay.
So 150 milligrams per
But,
package.
but I really feel like that's more, again, this is more of one of those policy decisions.
I know, that's why y'all are the experts. We're letting you control this field, and I want to know what y'all think is safe to protect our children and people from overdosing on stuff.
So I would introduce it somewhere between 250 and 100, somewhere in that range.
Okay, so I got the low
But
end
I
of the
haven't had
range.
any industry feedback on that. This is just me speaking about it publicly for the first time, and we didn't introduce this because we didn't think we were quite ready to have that conversation. So it hasn't been much of a conversation within the community here in Georgia yet.
Well, your department has got about 5 different hemp bills in all kind of different committees throughout the legislature. Have y'all thought about these issues before you're asking for this responsibility?
Yes, Mr. Chairman, we
Okay.
have. We specifically, though, did not address this particular issue at this time.
Okay. Any questions from committee members? Senator Summers?
Ms. Russell, thank you, Mr. Chairman. Isn't it true that if you limit it to 10 milligrams in a package and you have 10 gummies in a package, or 100 milligrams, whoever you want to say it, I mean, they're going to wind up, number one, that's the cost factor is there for the packaging. Number two, wouldn't it be true that the person that needs more is going to continue taking gummies, trying to get their pains to go away, and therefore, by the time they take 3 or 4 10 milligram gummies, they got 30 milligrams, 40 milligrams of gummies in their system, and then they're way overdosed, I guess is my point to telling you that. So if we limit it down to that amount, isn't it true that would cause harm on taking it that way? And if you limit it down to 10 gummies per package, they're just going to buy more packages.
I think the consuming public will purchase and consume what they choose to.
Absolutely. Thank
I do
you.
agree with that.
Senator Summers, you're in the industry. What do you think is an appropriate amount of milligrams per serving and per container?
When you're talking, thank you, Mr. Chairman, when you're talking about 0.3%, Mr. Chairman, you can remediate that down to basically anything you need to remediate it down. You'd probably be talking about a 20 milligram gummy will give a person some relief from pain. A 20 milligram will. Some people will take 25, but 20 will do it. And you need to have at least 20 in a package to be able to give people what they want, or they're just going to take more gummies. So you need at least that.
You got any idea why Tennessee, North Carolina, South Carolina, and many other states limit it to 10 milligrams per serving?
Because it's the mixture of the mix, Mr. Chairman. I'm assuming that's what they're doing, the difference of it.
Okay. Senator, again, you're recognized for question of the speaker.
Thank you, Mr. Chairman. I don't want to get too far into the drug business or medical procedures, but, you know, I suffer from allergies, and so there's this green pill that they sell me to drugstore that sometimes helps me with the cough and things that are associated with it. And when I look at these pills, the way that they're packaged is they're in single-dose packages. Said that you can break apart and you take a dose, and then you got 4 hours, or you take another dose or something like that. To fix this whole problem, why wouldn't we just say, hey, look, let's put it into single-dose packages that you have to do and something along those lines. I don't know if that's cost prohibitive or not, or what that would do to the market, but for me, that way somebody could. Even with my bad eyesight, I know, okay, well, that's a dose that I can take and don't have to read the label directions too hard.
I've heard feedback from law enforcement that they actually would like to see individual wrappers on gummies or other medium by which people consume THC. I don't think that it's totally outlandish. I do think that we would probably need to talk to people that are in the industry about what the cost would be. That is something that we've been paying attention to, but have not gathered the feedback from the community yet that we feel like we would need.
Senator Summers thinks he can
I
assist
think
in
I
that
can help
answer.
you with that, Senator, again. You got, gummies will come in gel caps, they'll come in gummies, they'll come in tinctures. And the fact with the tincture factor is, it comes in a bottle of your oil, and you can take more of it, and there's no way to measure it out. It's an eyedropper type situation. So if you package them individually, I don't think that's going to achieve what you're trying to do. They're just going to have them in that bottle or the tincture, if you don't mind.
Right, other questions? Thank you for being with us.
Thank you.
Thank you, Mr. Chairman.
I think it's time for a little comic relief. Aviva, are you here? And is Mr. Scribbles here? Whatever. All right, how did she sign up if she wasn't here? Yeah, where's Squiggles or whatever? Oh, he's a little slow getting out of bed this morning. All right,
We know how he feels, don't we?
Yolanda Bennett, you're with the Georgia Medical Cannabis Society. You can sit there at witness 2 if you'd like to, just for your convenience. I appreciate you being here the other day and your patience. We just having a hard time to get all these bills heard.
Thank you. Thank you for allowing me the opportunity to address the committee today. My name is Yolanda Bennett, and my journey to stand before you, well, I'm sitting now, has been both unique and challenging. For 7.5 years, I served as a correctional officer, a role that taught me to be profound and importance of rules, regulations, and safety of our community. Following my service, I embarked on a new path as a truck driver, where for 13.5 years, I crisscrossed this great country, navigating through vast experiences that diverse tapestry of America. This career was not my only broaden my horizon, but also diverse tapestry of American life. This career, I'm sorry, it's some other things going on, so forgive me. However, this chapter of my life came to an abrupt end when my health took a tragic turn, forcing me to the industry that had become a significant part of my identity. As someone who has also lived by the principles of duty and resilience, the transition to my life, dictated by chronic health conditions, was a stark and unwelcome change. It was during the challenging period that I discovered the critical role of cannabis and CBD products, THC, hemp products, managing my condition. These products, which I accessed through CBD stores, became my lifeline, offering relief and semblance of normalcy in my life. The debate surrounding HB 1322, its impact resonates deeply to me, particularly because of my background. I understand the necessity of regulations to ensure safety and order, a lesson ingrained in me throughout my career in corrections and a truck driver. However, I also stand before you as a testament to essential need for patient access to affordable cannabis treatments. Cannabis, I do say cannabis, but I consider cannabis and hemp to be the same thing because it's one plant. The CBD stores that now are under threat have been pillars of support for countless patients like me, providing quality products long before medical cannabis dispensaries became an option in Georgia. While I commended intentions behind the proposed packaging changes in HB 1322 aimed at preventing confusion of non-THC containing name brand products, I must express my concern for this bill's broader implications. The reality of my medical needs requires access to various THC treatment beyond the low-dose THC products at my medical dispensary offers, and a price point that doesn't exuberate my financial burdens. To safeguard against unintended access by minors, I firmly believe in the effectiveness of stringent ID verification process, a responsibility that should be shared by the retailers and adults alike. For outlets like gas stations where specialty knowledge is less common, mandatory certifications and education about hemp and THC could ensure responsible selling practices. In sharing my story, I hope to illuminate the complex needs of patients navigating life with serious health conditions. Our access to essential affordable care should not be collateral damage in the pursuit of regulations. Let us find a path forward that upholds the safety of our communities while preserving the dignity and well-being of patients. Thank you for your consideration.
Thank you. Appreciate you being here with us today. Tom Church, Church Law Firm. There you go.
Good morning, Mr. Chairman. Thank you, the committee, for having me today. My name's Tom Church. I'm an attorney here in Atlanta. I've got a robust criminal practice that takes me all over the state and the country. But for the last few years, I've been practicing a lot in the hemp space, and specifically representing individuals and businesses that have been targeted or threatened by law enforcement based on what I would call a misinterpretation of the law. I was able to obtain an injunction against the Gwinnett County District Attorney, who was threatening businesses, who had raided different businesses. I was able to get an injunction against the sheriff in Catoosa County, who was threatening enforcement actions, and y'all's esteemed former colleague, Jeff Mullis, was one of my witnesses in that case. And then most recently in November, we had the Elements case, where the Court of Appeals in a non-binding decision held that Delta 8 and Delta 10 are not controlled substances. Now, even though we had that opinion, since then, there have been additional raids throughout Georgia. I represent folks in Tifton, folks in Columbus, folks in Noonan, who have been either arrested or had their assets seized, or who continue facing a threat of prosecution. And the perspective I wanted to lend the committee today is that these folks are being prosecuted under felony marijuana trafficking statutes. They are being treated identically to illegal drug dealers. And I think we can all agree there's a difference between a hemp business, a business owner who is doing their best to comply with the law, and someone in a dark alleyway that's selling you some unmarked, unlabeled substance. And so I wanted to kind of bring that perspective to the committee when we're talking about, we all want clarity here. And candidly, even though it has benefited me as a lawyer, I'm all for being put out of business when it comes to this hemp stuff, because it really pains me to see some of these business owners being dragged off in front of their families in handcuffs. I've got a case right now against the district attorney and the sheriff in Columbus, who have prosecuted and seized all the assets of a business down there, despite the fact that other businesses right next door are selling the same exact stuff. And so if we want to put an end to these kind of lawsuits, I think it's so important for the legislature to get this right. And let me also add that because these are business owners and not drug dealers, a lot of them are supporting a lot of these regulations. I don't know a single hemp business that doesn't have a 21 and up sign on their store. I don't know a single hemp business that doesn't keep lab tests in their drawers to show that the products they're selling comply with the law. And specifically towards this bill and some of the other bills I've seen, I wanted to lend a little perspective of why these bills might not put me out of business, why we might still have these headaches from these kind of lawsuits. And that is specifically because the Farm Bill, in 2018, the federal Farm Bill, legalized a very broad variety of cannabis and cannabis extracts. And there's also language that suggests that the states cannot go in a way that is wholly inconsistent with those federal regulations. And that's where we get to the nitty-gritty about these other cannabinoids, Delta 8, Delta 10, HHC, right? And there are currently lawsuits in federal court in Arkansas, Indiana, that challenge these state laws that are more restrictive than the Farm Bill based on federal preemption. They're saying you cannot go against what the federal government has done here.
Have they been decided yet? Anything definitive been decided on that? Because we keep hearing FDA is going to extend their prohibitions beyond just Delta 9.
Right. I think we've seen some injunctions, but no final rulings yet and no higher court rulings.
Do you support the bill or not?
In the current form, no.
Okay.
And especially not with the additions that I saw this morning, which I don't think were.
The
I do like Senator Robertson. He presented, I think it's Senate Bill 437.
Yeah, we passed that.
Yeah, and he's
Out
from
of
my
the Senate, yeah.
Absolutely, and he's from my neck of the woods, Columbus, Georgia, and I know he is someone who's got some principled positions on these products. And as he said, the train has left the station. So rather than trying to ban things or try to effectively ban them through these really low milligram requirements or these excessive kind of regulations.
We're not trying to ban them. We're just trying to protect children and protect our citizens from overdosing on THC unexpectedly when they're told, oh, this is just a CBD product that there's less than 0.3% of THC in it. When you pile them all together, they can be a whole lot more than that. They can have psychoactive effect, right?
Right. It takes a village, right? We need responsible parenting. We need responsible shopkeepers. We need responsible law enforcement. And that's kind of why I'm here today, is because I want to see an end to the raids. I want to see an end to business owners being treated like criminals. And let me also add, I'm glad you brought up the FDA because they certainly have a stake in this too.
You kind of wrap it up.
Yes, sir. I was going to conclude with the fact that we've also had the federal government weigh in on this. The DEA, in several different contexts, have been very clear, more recently than in 2020, that Delta 8, Delta 10, all of these cannabinoids are explicitly legal. Unless they have 0.3% Delta 9 THC. So
Right.
one final word is I would say, as we talk about THC, as we talk about these different cannabinoids, we have to be specific because it's Delta 9 that the legislature targeted and it's Delta 9 that Congress targeted, and that is what the focus should be on, not trying to get rid of or push out these other products.
Thank you. Chris Brown. If I could get you to try to hold it to about 2 minutes. I got one more speaker, then we're going to take action.
Sure. Chris Brown, Cannabis Access, Reform, and Education. And I agree with the previous comments.
Could you say that again? Who are you with?
Care for Georgia is Cannabis Access, Reform, and Education.
All right. So you-
Right. So since 2018, we've been providing education to the general public, which includes civic leaders, politicians, faith leaders. I think the exploration of cannabinoids has been booming since the pandemic. I think as people sought to have therapeutic relief and as the industry opened up, we see more retail spaces open up for access, even as we hadn't been able to expand our program here in Georgia with the low THC program. I think that we do need some form of compliance. I do understand some of the regulations that is needed to provide structure, but I think that we have an overreach in what we're trying to do. This bill is not favorable as written, especially not as amended. I think that with all the bills that's floating around, that we could actually put together a comprehensive plan to include some of the impact that we don't know and getting input from some of our providers and being able to still move that forward if we involve those people and people who represent those bodies. So it's not favorable as written. I look forward to you guys striking this down, coming back to the department to put in some favorable amendments. I think that as we talk about age restrictions, we do have patients that was at the time that we voted on this, may have been under the age of 18. Some of them are over the age of 18. Some of them still below. They're still patients seeking relief to find medicine in which ways that Georgia don't provide.
So you don't like the under 21 prohibition?
Well, I'm just acknowledging that there are people, there are still patients that are under 21. So nobody never takes that into consideration as we talk about children. We leveraged our bill about patient advocacy around children. And so I'm a patient and caregiver. And so as a caregiver to my mother, and to also understanding people who are patients to children, they become patients themselves. So therefore, you start to see a reach to alternative medicines that's legal, and this is what hemp-derived products are given.
Thank you for being with us today, Mr. Brown. Last speaker, Michael Mumper.
Thank you, Chairman, and the Senate Committee. I'm Michael Mumper with Georgians for Responsible Marijuana Policy. We see that this bill is trying to legalize and regulate hemp consumables, limit bad actors, and keep our kids and citizens safe. 1322 does a very good job of setting up that framework for regulating. However, unless we include Delta 8 and the other synthetic cannabinoids, we're going to miss the mark. Why is that important? 4 reasons. Journal of American Medical Association, Poison Control, our Georgia Board of Pharmacy, and then I'm in 19 states. Journal of American Medical Association just published an article in a study by USC's Keck School of Medicine that 11.2% of our 12th graders in the country are using Delta 8 products. Those numbers are higher in the Southeast. Secondly, Dr. Gaylord Lopez from the Georgia Poison Control Center tells us that there have been over 250 calls of toddlers 6 years and younger overdosing from Delta 8 products in the last 3 years. So Dr. Lopez is very concerned about Delta 8 remaining a legal, unenforced product. Thirdly, our own Georgia Board of Pharmacy in Rule 48034.04 has the following 5 points to make about synthetic cannabinoids, including Delta 8. A, that synthetic cannabinoids have an extremely high potential for abuse, that scientific evidence and scientific knowledge of the pharmacological effects of these compounds demonstrate that the public is at extreme risk if they are not regulated as controlled substances. And again, this is Delta 8. That the pattern of abuse of these compounds and the scope of significance of that abuse support regulation. That there exists an imminent peril to the public health and welfare with regard to the abuse of these compounds, and that these compounds have the same risk to the public health of citizens of the state of Georgia as other substances already contained in Schedule 1 of the Controlled Substances Act.
That's the Georgia Pharmacy Board's
That's right.
position. And is THC a Schedule 1 drug?
Yes, it is.
Okay.
Yes. I will say that Wyoming just became the 19th state in the country to ban Delta 8 products 2 days ago. And I'll finally add that Colorado and California, which have years of experience of recreational marijuana, have landed on 10 milligram doses of hemp consumables in packages limited to 100.
All right, I'm going to have to cut you off there. Thank you. There's a lot of my members are about to have to go to Appropriations Committee. We are going to continue our hearing, but first of all, is there any motion on this bill?
I got a motion, Mr. Chairman.
What's your motion?
Table this bill, Mr. Chairman, it needs more work.
Is there a second? Second from Senator Anderson. What's the pleasure of the committee? All in favor of tabling, raise your hand. 1, 2, 3, 4, 5, 6, 7, 8. All opposed? 4. The bill is tabled. Thank you for being here today. All right, I got several committee members. You are free to leave to go to appropriations, but I want you to come back because we're going to be hearing this bill on HB 1077. Senator Lucas, I am going to recognize you since you have requested this, and you can stay where you are, or you may go to the witness table, or you can go to the podium.
Thank you.
Mr. Chairman, I'd like for Laura Colbert and Russ Harris to join me because
That'd
they've
be
done
just fine. We are working off of a committee substitute prepared by you or on your behalf to HB 1077. It's LC 52055-7S.
First of all, I want everybody to know, and I want to thank the chairman. This is not an I bill, this is a USM bill. USM, as my grandmama would say. We started out on this conversation about Medicaid expansion and CON need to travel together. There were some things in CON. And for 49 years I've been here, the CON really has never been pierced. No major changes to CON. What I'd like to do is talk about Medicaid expansion. This act shall be known as the Peach Care Plus Act of 2024. Findings. The legislature finds that expanding access to coverage for essential health care needs to Georgians earning up to 138% of the federal poverty level will improve the quality and availability of health care services in this state. It is important that federal reimbursement remain at current rates to allow the state of Georgia to provide such coverage. Providing coverage via fully subsidized commercial insurance products on the section of 1332 Marketplace in Georgia will give individuals more options in coverage and help to ensure that health care providers may commercially contract for the services and receive fair reimbursement for providing such services. Adoption of a joint resolution of the General Assembly. This section shall not apply to a waiver application with associated amendments submitted and approved pursuant to this act prior to October 31st, 2025. Authorization form of expansion. The department shall consultation with the Office of Insurance and Safety Commissioner, submit a waiver request for approval along with other necessary amendments on or before October the 31st, 2025 to the United States Department of Health and Human Services Centers for Medicare and Medicaid Services pursuant to Section 1115 of the Federal Social Security Act, which shall include the following. Enrollment for certain low-income individuals making less than 130% of the federal poverty level in the eligibility category created by Section 1902A 10AI 8 of the Social Security 20 Security Act for 42, and that's federal code, 42 USC 1396A into qualified health plans offered on the state marketplace. Established under 1332 of the Affordable Care Act or the federal marketplace as applicable at implementation. Full payment of any premiums or other direct costs associated with enrolling in qualified health plans for certain individuals making less than 138% of the poverty level. The provision of this section shall only apply so long as the state federal medical assistance percentage for the state established pursuant to 42 USC 1396D for a population covered by waiver remains at or above 90%. It is the intent of the General Assembly that all savings to the state as a result of this act shall be deposited into the Indigent Care Trust Fund for program expenses described herein. Payment of such funds to agencies of this state as may be required to pay any additional state costs associated with the Peach Care Plus program. The program created by this act shall be a program of the Department of Community Health and named the Peach Care Plus program. If the waiver as described in this section is not substantially approved by CMS before April 30, 2025, then the provisions of Section 5 of this act shall become effective. Fallback plan. An individual is eligible for coverage of health care services, medical assistance provided pursuant to this article if the individual meets the requirements of 42 U.S.C. Section 1396A 10A I8. We're talking about putting up an advisory council that would deal with this. This has created the Advisory Commission on Peach Care Plus, which shall advise the department in drafting, submitting, and implementing the waiver provided for in this act, which shall consist of the following members: the Commissioner of the Department of Community Health, or a designee who will also serve as chair. 3 members of the majority party in the Georgia Senate appointed by the President of the Senate. 2 members of the minority party in the Georgia Senate appointed by the President of the Senate. 3 members of the majority party in the Georgia House of Representatives appointed by the Speaker of the House. 2 members of the minority party in the Georgia House of Representatives appointed by the Speaker of the House. The Commission consult with the Department during preparation of the waiver requests authorized by this act and review such waiver prior to submission. Issue a public report no less than 30 days after submission of the waiver making recommendations for implementation and success of the program authorized by the waiver. Seek to make all recommendations in a bipartisan manner, with the chair only voting on any recommendation in the event of a tie. Receive for legislative members the same per diem expenses allowance as that received by members of the General Assembly for 5 days of study and review of this topic, and for each day member is in attendance at a meeting of the Commission. Remain in place on ongoing basis with members serving at the pleasure of the state, official appointing them to advise the fund created by this act on its ongoing. Now, Mr. Chairman, we introduced 487, which was Medicaid expansion bill. That bill had a work program in it.
That's a bill you filed that got assigned to our health committee.
Right.
This committee has not heard that.
That's right. And what happened over the time, as I was walking down the hall the other day, Senator Brass came up to me, and he said, Luke, you can't put a work component in it. The courts have ruled that it is insurance and not a work program. And so what we discussed and what I discussed with Senator Brass.
Let's be careful talking about private conversations between senators.
Well, you know,
Okay. He may share those.
That
That helps us have candid conversations.
right.
To have them remain confidential.
What he said to me, he said, Luke, the courts have ruled you can't put a
He's
work-
waived attorney-client privilege. He's waived,
Yeah.
he's waived legislative privilege. You
I'm
go
not-
right ahead.
I'm not an attorney, so I can't be disbarred. What he said is you can't put work into your bill because they've all been turned down by CMS and the courts ruled that it is an insurance program and not a work program. What we discussed is the North Carolina plan included workforce development because our job is to go out and try to get folks and put them in a position to go to work at various places. So I agree with him that it need to be amended because they approved the North Carolina plan with workforce development in it. As we talk, you and I talk, and excuse me again, we talked about the two need to travel together. There were some things that we need to do on CON to help rural Georgia. And we in the Senate passed the CON bill to do exactly that. One of the things that happened is if a OBGYN wanted to set up an office with a pediatrician and it was not at the hospital, they had to get a CON, which is ridiculous when we talk about infant mortality. Who gonna see about the children when you get them delivered? The pediatrician. The hospital in Colquitt County closed and they wanted to reopen. And they told them 24 months to 18 months before they have a hearing based on CON. And what we did in the Senate was to try to take care of that particular situation. There has been a problem with CON, especially when you're talking about a hospital being built within 35 miles of another hospital. Back during the day, what CON was doing was those not-for-profit hospitals who took in everybody to keep those hospitals that made money and that would pick or cherry pick the patients that had insurance. That's good. Today, competition is good. What kind of service you provide. As a football player, I had to compete. If I didn't, I was on the bench, I wasn't on the football team. So every day when you go to practice, you had to compete. So I think competing is a good thing. It opens up the door to many things in healthcare. Finally, I want to talk about COVID taught us an experience. Had we had those 12 rural hospitals that closed, our death rate might not have been as high in Georgia. To give you an example, I had a buddy of mine that lived in Hancock County. I tried to get him a bed. All the beds were full in Augusta and everywhere. He left and had to go to Pensacola, Florida to get a bed. He died there, not having family around. We have an opportunity in Georgia to try to see about Georgians in healthcare. Everybody wants to live a long life. I want to live as long as Methuselah, but I don't know how I'm going to make it without healthcare. And so I bring to the Senate the opportunity to have the Medicaid expansion discussed between the House and the Senate. How much money it costs, what kind of plan you're gonna use, what are gonna be the rules in getting health care in Georgia. Rural hospitals have a problem, bed occupancy. And when they take in folks who can't pay, it's called uncompensated care. Now, I've talked to, where the hell go again? I've been talking to everybody across the aisle to help me do this. Senator Burns talked to me. Somewhat. We talked.
You're not going to have many senators left willing to talk to you if you keep telling everything they say. That's the reason for that professionalism between us.
But the conversation was good. Burns knew more about hospitals. He served on the boards and uncompensated care. He told me, look, if you can't pay the bill, the county is trying to get up the money to keep the hospital open, as well as to make sure those folks who work at the hospital have a job, and also to see about their health care. In talking to you and the lieutenant governor, it's about telling the truth. This ain't no Democratic thing. This is us, all of us, because it takes Republicans as well as Democrats to try to work this deal out so that we can see about health care in Georgia. Now, with that, any of the specifics that you want to know, I have Ross Harris and Ms. Colbert here because they helped me try to put this together. I am not a lawyer. I'm a street lawyer. I learned everything from the street. And so what I say to you all is we can't kick the can down the road anymore. 1.2 billion is in D.C. waiting for Georgia to expand. But how long will it be there? Mississippi did it 2 weeks ago. You don't think that those folks in Congress are not looking at that 1.2 billion and say, well, y'all are not using it, and so we want to get it. And what we have to understand, when we give departments in the state of Georgia money and they don't use it, we go back and we recoup it and do other things with it. And with that, for those of you who have any questions, I'd like for you to go ahead and ask me about it now, because I got the folks can talk better about it than I.
All right. Ross, would you like to speak, to explain the bill, or who you? I defer to Laura. All right.
I'd be happy to. So, thank you all for having me here this morning. I'm Laura Colbert with Georgians for a Healthy Future, and we are a health policy organization representing Georgians here across the state. So this bill really lays out the authorization for our Georgia Department of Community Health to work with CMS, our federal government, to seek permission for a waiver program that would extend health insurance to adults making less than 138% of the federal poverty line. And the way that health insurance would be secured is that the Department of Community Health would purchase private health insurance plans, just like those sold on the Georgia Access Marketplace, on the Governor's Marketplace. And so folks would get private health insurance, and those costs would be covered by the Department of Community Health. There's an advisory group that would be set up to kind of help advise and recommend about how this waiver should be put together and implemented. And there is a time frame established for ensuring that this waiver is submitted and approved by October 2025 of next year.
So this is not a full Medicaid expansion. It's similar to the Governor's Pathways program.
It would go beyond the Governor's Pathways program, so it would extend coverage to to individuals up to 138% of the federal poverty line. Pathways stops at the poverty line.
The advantage of doing it using private insurance, as you suggest, is that it gives a higher reimbursement rate to the medical providers,
Exactly.
higher than Medicaid.
Yes.
So it's better than Medicaid expansion to use a waiver of some type.
It depends on what problems you're trying to solve for the state, but it can be advantageous in
You're
that way.
doing something similar to what the governor has done, but more aggressive.
Exactly. Yeah.
Why
And
shouldn't we give him a chance? Why shouldn't we give the governor a chance to see if Pathways can succeed before you cut his legs out from under him? I mean, he is working hard. COVID stalled it, as Senator Lucas said, and it has not gotten the traction it wants. But now that we're beyond COVID, trying to get further approval, I can't remember the procedural problems, the granting of the waiver, the yanking it back, and all the politics involved in that. I am curious why it wouldn't be wise to give the Pathways program a chance first. The CON bill that we've passed has a commission to study expansion of medical services through all types of ways, insurance. Give that a little time. I'm just wondering, I know we ought to have this discussion,
yeah.
but I'm not so sure that it's the time to move forward with until we get some resolution on what's already in play.
Yeah, I think that's a really good question. What Peach Care Plus, which is kind of what this bill would name this program, would do is kind of secure the enrollment gains that have been made by Pathways, and it also builds on the success of the Georgia Access Marketplace. So again, kind of both of the governor's key health policies.
That has had some success, the Georgia Access.
Yes, it's had
program.
incredible success, real enrollment growth over the last couple of years, and that's been very exciting to see. So what this would do is help to draw down some very lucrative federal incentives for the state that go beyond what Pathways is able to do. So regardless of how many folks enroll in the Pathways program, it will always be costlier per person than a program like Peach Care Plus because it pulls down those federal incentives. So Georgia would earn that 90% match. The federal government would pay 90% of the costs, whereas Georgia would pay 10, and we would also earn a 2-year sign-on bonus that, as Senator Lucas referenced, is estimated by the state auditor to be $1.2 billion over the first 2 years of the program.
Okay. Questions of committee members? Senator Summers, you're recognized for a question.
Thank you, Mr. Chairman. Could you please walk me through how maybe the question should be this right here. The indigent care that we're dealing with in Georgia is massive. Does this take care of that? Can you touch on that?
Yes, so this program would cover, again, kind of based on the state auditor's estimates, somewhere between 500,000 and 1 million Georgians over the first 3 years of the program. Georgia has the third highest uninsured rate in the country, and so this would go a long way in reducing that uninsured rate, making sure providers get paid when those folks seek care, and it really allows those folks who are currently uninsured to take control of their health care, to manage their health care, and make informed choices about getting preventive services, picking up their prescriptions, rather than going to an emergency room, which is kind of their only choice at the moment.
May I follow up, Mr. Chairman?
Yes.
Follow up. I like that, but are we incentivizing people just to continue to use the system to be indigent care and go to the hospital at 5 o'clock or 5:01 when the doctor's office is closed?
So I think by giving people health coverage, you give them more options, right? So most people don't want to go to the emergency room at 2 or 5 o'clock in the morning. They want to go to see a physician that they know and have a relationship with. And so by giving them insurance, you give them that option to do that. When they start getting that tickle in their throat, they go to the doctor first instead of waiting until they have a 100-degree fever and they're at the hospital. So we believe that providing folks with coverage through this program really alleviates that indigent care problem. Certainly, it won't take our uninsured rate down to zero, but it would be a massive reduction in how many uninsured Georgians we have.
Other questions from committee members? Senator Brass.
Thank you, Mr. Chairman. And I just wanted to kind of clarify on a conversation I was having with an unnamed senator whose name may rhyme with rhyme with
Sitting here at the table.
mucus. That conversation was, there was a couple of things I was interested in, and reasons why I was open to looking at this when in the past I've been against. So some of those are, we do continue to see our rates rise throughout the state for the insured. And then when the insured go into the hospitals and the emergency rooms are stacked up and a lot of that's for reasons that was just discussed. People are going there because they can't be turned away. And so it's not just a problem for uninsured, but it's also, we're having problems for the insured. And I do think the Pathways, I think that program has opportunity to work, and I do think it can work, but we're only talking about up to 100% of the poverty level, which I think is about $15,000 a year. And when we take it to 138, I don't know what that number is, but if I remember in the past, it was maybe around the $24,000 a year. What is it, Madam Leader? You may know better.
I think it's about 31.
Okay, so $31,000 a year, which after the massive inflation we've had over the last several years, that's just that's unlivable. And as a small business owner who can't afford insurance for my employees, and these my guys are hard workers, and there's not always 80 hours in a month for them to work, but they are making more than $15,000, but they may not be making $31,000, and I pay them well, but on an hourly basis, and sometimes roofs leak, sometimes they don't, and so sometimes they're not going to qualify for Pathways, and they're certainly not going to qualify based on 100%, but they would on 138, and I do want my guys insured. I do want them to be able to go to get preventative care. So that's what kind of got me finally open to this idea. And this unnamed senator that rhymes with mucus, couple things I discussed that I'd like to see in it. It wasn't just the work requirement piece, but there was also a trigger. I wanted a trigger if the federal government ever came in and said we're going to do less than 90%, then the state could back out. And I do see that trigger, I believe, in lines 62 through 64. So I'm glad to see that. As we did discuss, the work requirement caused issues. I know the Arkansas plan, from my understanding, is every time they applied for the waiver on the workforce requirement, it did not work. They were turned down, is my understanding. But as we discussed, North Carolina, the way they worded it with a workforce development type fund, that did work, and it did pass muster, and it was accepted by, I guess, CMS. And so, should this proposed bill get a motion and a second, I would be offering an amendment to add in a workforce development fund that would kind of help alleviate some of my concerns.
Other committee members have questions. Dr. Ritt.
I refer to the... No, go ahead. No, you good. I'm good. Thank you, Mr. Chairman. I was talking to Senator initials DL, and any of y'all can answer this. I have a few questions here. For every dollar we spend, did you say that we get $9 back from the federal government? And so that money's up there collecting interest?
I don't know if it's collecting interest in Washington, D.C., but yes, there's a 90% match. So for every dollar Georgia would spend on this program, we would draw down $9 from the federal government.
I was thinking, if you build new hospitals in underserved rural areas, the people will come. But without insurance, that can be counterproductive if they come without insurance, right?
Yeah, that puts a strain on rural hospitals when, and really any hospital when folks show up without insurance, not by their choice, but it makes it much more difficult for rural hospitals to remain financially stable. And when you increase their patient load that has coverage, that makes it a lot easier for them to kind of stay.
How much do you think y'all
strong.
think it'll cost to build a new hospital?
I am not an expert in that area, so I would defer to our hospital friends.
Okay. I think you said that more people are reluctant, if they had insurance, they would be reluctant to go to the emergency room than to a doctor. Because I remember one of my colleagues, whose initials I won't say, had to go to the emergency room in an ambulance. And when they found out what the cost was, they caught a cab.
Yeah, I mean, I think what this, for the folks that would gain coverage under a program like this, a surprise, or unexpected medical situations like that can be a big hit. Even, for some of us, we can handle an unexpected $500 or $800 medical bill, but these are folks making $20,000 a year, and so that's a really big hit. So I think you bring up a good point that by providing them with coverage, they're financially protected as well as enabled to go to a physician, hopefully before an emergency happens.
When I was in the Air Force, I managed fitness and health for the pilots, navigators, load masters, and flight engineers. And we found out how important access to health care has an effect on the mission. When we called people up for the first Gulf War, a lot of the people we called up didn't have health insurance, didn't have dental, so we had to send them to a doctor to get and a dentist before we could train them to go fight. It's kind of hard to shoot when straight when your teeth are hurting. But we developed a program, TRICARE Healthcare, which is a part of their readiness package. And I think you can equate the same thing to Georgia. Our most precious product here is human capital. And if we're going to continue to expand and be known for business and bring companies in here, we want to have a healthy workforce where people have access to health care. Thank you. And what's your initials again?
Senator Albers, you're recognized for a question.
Thank you, Mr. Chairman. This may go to the bill's author. Do we have a fiscal note on this bill?
Around 580 million is what it would cost us, from my conversations with other folks, about $580 million to start the program.
That's a pretty significant number, Senator.
There is no question about that, but you got 1.2 billion sitting in Washington for you to draw down.
Mr. Chairman, isn't it usually appropriate that we'd have a fiscal note with the bill in committee?
That would be the normal practice.
Okay, thank you.
Senator Harbison, did you have a question? Yes. I'll get to you next.
I really want to take this opportunity to make some observations and really thank a lot of people involved in this process so far from an optimistic perspective. I know a lot of work went into where we are now. It may not seem as if we're making progress, but I remember going around the state from the north, south, everywhere with the senator with the initials DL and the senator from the 51st. I was on both of those study committee trying to take a look at health care and its good side in the state of Georgia. So I just want to commend the chair and everybody involved in this and all of the moving parts that have to come together for at least us to take a serious bite out of this apple that I think ultimately we're going to have to face one day, one way or the other. So I just want to commend us for at least coming together to have a good conversation with that, hopefully with some positive outcome. Thank you, Mr. Chairman.
Thank you, Senator. Your diplomacy and statesmanship are always appreciated and a great example to all of us. I got a question from Senator Summers.
Would you address the illegal situation when it comes to the health care? How are we going, I mean, I want this to apply to Georgians, and I like anybody to come to America, but I want them to come legally. How will that be handled?
Only legally present individuals would qualify for coverage.
Only, say it again?
Only legally present individuals would qualify for coverage.
What qualifies them as legal, I guess?
I'm not an immigration expert, and so my
Not a driver's license, I mean, just.
I think it would take more than a driver's license. But again, I would defer to an immigration expert on that.
Okay.
All right, other questions from committee members? We got a few other people to be heard. We are on a time limit since we go in at noon today and have other meetings really at 11. But I've got a few folks here, if you'll kind of try to keep your comments concise. Natalie Crawford, Georgia First. You'll just take the podium, be great. Thank you.
Thank you, Chairman and committee. I appreciate the opportunity to make some comments on House Bill 1077. Again, I'm Natalie Crawford. I'm the Executive Director of Georgia First. We're a nonprofit conservative think tank here in Georgia. As a former two-term county commissioner in Habersham County and a fiscal conservative, from a local level, I understand the hours of deliberation that you guys put into policies like these and the responsibility that you carry for your communities and the state as a whole, and the desire to get it right. The language here seems to reflect that Senator Lucas worked pretty closely with the majority party on this language to present a free market-based approach, and that's smart policy. I want to commend you guys for that. There is a critical need to close the health care coverage gap in Georgia, and the initiative is not just about ensuring access to health care for our citizens currently in the gap, but it's about making a smart fiscal choice that will lead to positive economic outcomes, job creation, and the stabilization of rural hospitals across the state. Right now, our tax dollars are subsidizing Medicaid programs in 40 other states. Peach Care Plus would inject much-needed funds into Georgia's economy, driving growth and economic opportunity. Studies have consistently shown that states which have closed their coverage gap and expanded access to health care experience significant boosts in their GDP. By extending health care coverage to low-income individuals and families, we empower them to lead healthier lives and contribute more effectively to our workforce and economy. Healthier citizens are more productive, which leads to increased economic activity and a stronger state GDP. Investing in the health of our people is an investment in the economic future of Georgia, and our strongest business leaders know that investing in their people, the health of their people, is a long-game play by leading to better retention, higher revenue, better productivity, and fast-tracking growth. Recent studies published in the journals of both health economics and public economics found in states that had closed their coverage gaps, there was increased employment among low-income childless adults, and particularly for individuals with chronic conditions who were previously unemployed but could re-enter the workforce. So this is about the long game. Closing the gap will also result in job creation across various sectors of our economy. The healthcare industry itself will experience expansion as more individuals gain access to preventative care and seek treatment for chronic conditions. Additionally, increased healthcare spending generates a ripple effect throughout the economy, creating demand for goods and services and stimulating job growth in related industries. From healthcare providers to construction workers building new healthcare facilities, the benefits of Peach Care Plus would be felt by workers across the state of Georgia. And maybe one of the most pressing issues facing our state is the closure of rural hospitals due to financial strain. And while we haven't seen a closure since 2020, I think it's important to remember that many of our rural hospitals were propped up by substantial COVID-related federal funding. Habersham Medical Center is a prime example. We spent 7 of my 8 years on the commission working to save that hospital. And were it not for a 5-year purchase agreement that we were able to secure with Northeast Georgia Health System, Habersham Medical Center would have closed its doors last year when those COVID federal dollars ran out. So, expanding access to health care in this state and closing the gap will provide a lifeline to those struggling hospitals, ensuring they can continue to serve their communities and provide essential health care services with more patients able to afford medical care. And I don't need to tell all of you what a hospital means to communities in terms of economic opportunity. We really need only look to Richland, Georgia, for an example of how severely the loss of a hospital affects local communities. And finally, through Governor Kemp's leadership, we have a healthy state exchange that's unique to Georgia. Peach Care Plus would make the Governor's Georgia Access Marketplace even stronger and provides us an opportunity to model a truly innovative approach to health care for our people and a pathway not just for expanding access to quality care, but also strengthening our overall economy. So I would urge you guys to seize this opportunity to continue our state's legacy as the #1 state in which to do business. I also want to applaud Senator Brass for the workforce component. I think that what you shared and what you would like to amend is vitally important. A waiver gives us state budgetary control. Georgia First has been a strong proponent for a waiver process, and so again, appreciate it.
So you guys agree that the Governor's Georgia Access Program is a raving success?
Absolutely. I think.
And you think the private option insurance is also the right way to address the plan through a waiver? Requires a waiver to get that, right?
It does require a waiver. We 100%.
Yours is just a little more aggressive of a waiver here.
Right.
All right.
We 100% support the waiver process for qualified health plans on the state exchange.
All right. Sounds good. Thank you for sharing with us today. John Hochter. Try to hold these comments a little bit quicker, please. If we're going to be able to have a vote today, we've got to wrap up the testimony.
Thank you, Mr. Chairman. Thank you to all the committee members. I will keep my comments brief. My name is John Hochter. I'm the Managing Director of Advocacy for the American Cancer Society Cancer Action Network. We want to thank you, Mr. Chairman, and the committee for allowing this bill to be heard today. Access to health insurance is the #1 determinant of cancer survivorship. But right now, more than 400,000 hardworking Georgians live in the coverage gap, meaning they make too much money to qualify for Medicaid and not enough to afford private insurance. These are hardworking Georgians, farmers, veterans, child care workers, caregivers. We must ensure these families and individuals have access to affordable, comprehensive health insurance that gives them access to screenings to find cancers at an early stage, leading to higher survival rates and more affordable care. Georgians in the coverage gap include a 42-year-old grocery store clerk, LaShonda Harrell, who has stage 4 metastatic breast cancer. She needs a potentially life-saving scan to evaluate her cancer spread. However, without any coverage, she cannot get it. She would qualify, though, for the Peach Care Plus program. Closing the coverage gap is also a great deal for Georgia. Other states have been reaping the benefits of the federal tax dollars that Georgians are sending to Washington, D.C., with 90% federal match rate and an additional 5% on the new enrollees for 2 years. Peach Care Plus will keep more than $4 billion in tax dollars right here in Georgia. Ms. Harrell and hundreds of thousands of your constituents without health care don't have another year to wait. It's heartening to see the renewed interest in solving Georgia's health care crisis. We urge you all to agree on this and pass a Georgia-based solution to closing the coverage gap in 2024. Thank you, Mr. Chairman.
John, you're a registered lobbyist here. Have you reviewed the CON bill that's passed the House and the Senate? It's kind of in negotiations now.
Yes, I am.
Do you
1339.
agree that that helps cancer patients if that bill passes?
We believe that there is kind of a relationship between the two pieces of that puzzle. We need to provide the access and coverage and insurance, but we also need to have the hospitals that are able to see these people, to develop a patient relationship with those folks who need to have that access.
You have
in
a
their
cancer
community.
center in Athens that's very actively supportive of that bill. Do you know, UCBC?
Yes, sir.
Okay.
Yes, sir. We agree with this. We think it's the
I'm
right
not talking
move.
about this one now, I'm talking about the CON bill.
1339, correct.
Yeah, they're separate bills.
Yes,
Yeah.
sir.
Okay,
Yes,
thank
sir.
you. All right, Julie Wyndham.
Good morning, Mr. Chairman and members of the committee. I'm Julie Wyndham with Atrium Health. We have hospitals in Northwest Georgia and in Central Georgia. And I first would like to thank the sponsor of this substitute. We have two great senators from Macon in the committee today, but particularly the sponsor of this substitute. It's been a tireless effort for rural health care and for this issue, so we appreciate that, Mr. Chairman. I just want to point out one issue that has not been brought up today. You've heard a lot of great reasons for supporting closing the coverage gap, but the issue that I want to talk with you about today is improving our maternal mortality and morbidity rates. We know that if a woman is healthy when she gets pregnant, she is much more likely to have a successful pregnancy and give birth to a healthy baby. So we think closing the coverage gap goes a long way in getting preventative care to women who are likely to become pregnant. You guys, under the leadership of Governor Kemp, took a great step in extending coverage 1 year postpartum. We think this is the next step in addressing that crisis. Happy to answer any questions, Mr. Chairman.
Did Atrium Health, do they support that CON restriction bill that we have?
We support some parts of that legislation. We think there's still some pieces that need a little work, but we look forward to working with you guys and the House on that legislation and hopefully moving forward on that.
Linda Hamrick, you here?
She would like to wait for her.
Oh, amen. Bless you. Bless you. All right. Anna Adams.
Thank you, Mr. Chairman, members of the
morning.
committee. I'm Anna Adams with the Georgia Hospital Association. We represent more than 140 hospitals in the state of Georgia, ranging from small rural all the way up to large urban. We are encouraged by this conversation today. GHA has a longstanding position of providing coverage to the uninsured in Georgia. We think a healthier patient or an insured patient is a healthier patient. And while we are very grateful for all of the expansion efforts that have happened over the last several years, we would love to continue moving the needle on this conversation. One question we do have about this legislation, having seen it this morning, that we would love to get additional information on is the pay for. It does come with a pretty hefty price tag, and so just thinking through the logistics on that, I know is something that is top of mind for you all. So would love to be a part of that conversation moving forward, but again, very encouraged by the continued effort to get coverage for these uninsured individuals. Happy to answer any questions.
So am I reading that as it's not quite ready for prime time, or you're not able to endorse yet? You're worried about how much it's going to cost us? We're
I think we'd just like to get some additional information.
not in a position to support this yet.
We support all efforts toward covering the uninsured, but we do want to just get some info on how much this would cost, where that funding comes from, et cetera.
Okay. Any questions for Ms. Adams? All right. Boyd, Strength.
I appreciate the committee allowing me to speak. My name is Boyd Stow, former Air Force. Who's talking about Loadmaster? Well, I wasn't on the. I was a flying crew chief. Is that enough? All right.
You got any comments about the bill? Let's hear
Yes,
them.
sir. I was
10
there.
minutes.
Yes, sir. As a veteran, I was actually in that coverage gap. When I was going through law school in 2015, actually, injury that I sustained while deployed to Afghanistan went from nagging to debilitating. And by debilitating, I mean excruciating, to the point where I was not only in pain all the time, losing sleep, mental faculties affected in law school, but also ultimately lost the use of my left leg. The only good the VA was to me at that time, I wasn't really kind of fully in process, if you will, was prescribing opioids. And so I really spiraled out of control for a while. It wasn't until the VA it took me and recognized that I was probably going to lose. I was going to lose control of my bowels. That they gave me an MRI, and a week later scheduled me for surgery. And post that surgery, my life has been completely different, right? But I didn't have coverage, all right? And I didn't have options. And I understand what it's like to live at the intersection of poverty and pain. And anybody who's never been in extreme poverty, which I was at that time, doesn't understand too, like what it feels like when you are without and you don't have a way out.
As a veteran, wouldn't you have VA hospitals available to you?
Of course you would.
Do you need Medicaid to get treatment there?
So in 2015, I had only I'd only take, so I don't know how familiar you are with the process of going from the military to the VA. The process isn't taken care of for you. It's a very convoluted process. Veterans that are getting the attention that they actually need it's because they've actually endured a very lengthy process. They've had the help of an advocacy organization, again, over time, or they've, like in my situation, they ended up being presented right in an ambulance, right, actually for the 4th time that month to the ER. And ultimately something was done about it. But the point is that I understand what it's like to live in that space, and there's 30,000 veterans of that 434,000 uncovered in Georgia. 30,000 are veterans, and I'm sure a lot of them are kind of in the same situation I was. So I just want to advocate for that. That's the other thing, and I have another hat I like to bring because, as I was...
Tell me what Bridge Georgia is. You signed up on behalf of an organization called Bridge Georgia. What is that?
Yes, sir. So Georgia First is the organization that's actually advancing Bridge. So Natalie was up here just a minute ago. So I'm advocating on their behalf because I definitely believe in the need to supply coverage for veterans. And I just want to also say that when you just look at the numbers, I've been doing revenue modeling now. I'm a software, I'm an attorney. I'm a software company owner. I've been doing revenue modeling for a number of years. And when I look through all the numbers, the thing I think needs to be most considered is the opportunity cost of inaction. And right now, that's the biggest thing. That should probably be more of the conversation than anything, is there's a massive cost to inaction. And the last thing I'll say is I don't know how much you guys are following AI, artificial intelligence, and the impact it's going to have on workforce. Do you guys follow any of that and take it seriously? Because you certainly should. In a recent poll, 46% of large corporations said that they intended to replace 1/3 of their workforce in the next 2 years with automation. So, what are we going to do?
Not before us today, but we got a lot of committees. We're going to get to that
Yes,
one
sir.
later.
Thank you for your time.
All righty. Leah Chan.
Hi, I'm Leah Chan. I'm with the Georgia Budget and Policy Institute, a nonprofit, nonpartisan organization focused on our state's budget. So I did want to follow up on a comment earlier about how we would pay for this. So as has been mentioned a couple of times, according to the state auditor, we would be getting a sign-on bonus that would bring over $1 billion in additional federal funds to our state, which is more than enough to offset the state cost of Peach Care Plus for the first 2 years and generate about a $630 million surplus that, as the bill states, would go into that Indigent Care Trust Fund. So just to put a finer point on that, Peach Care Plus would be completely paid for the first 2 years, and we would still have money left over to use for other critical state needs. So after those first 2 years, Georgia would pay about 10 cents on the dollar for newly eligible enrollees. Other states, like Arkansas, have actually seen that the actual net price of closing the coverage gap is well below that 10% sticker price, thanks to increased revenue and state budget savings. So the state auditor estimated that after the first 2 years, the state costs would be between $516 to $566 million per year. But that amount, again, could be offset, like it has been in many other states, by other revenue, like our state's existing hospital and nursing home provider fees. So thank you. I'm happy to answer any questions.
I keep circling back to, I'm so impressed with the work that our Lieutenant Governor, Jeff Duncan, some years ago, and Governor Brian Kemp put into the Pathways program, the Georgia Access, and it seems to be universal acclaim for the Georgia Access, how that has been very successful in increasing enrollment. And it seems like we're in midstream trying to get the waiver finalized on the Pathways program so we can see if that works. And it's so similar to this in using private insurance. Do you see a downside to giving it a chance before essentially undercutting it by going a different direction here? I don't see how Governor Kemp gets his waiver if we are not supportive of it, is my concern.
Yeah, so the Georgia Access Model has seen great success, and Peach Care Plus is really an opportunity to build on that. I mean, for example, I think in this last enrollment cycle, we saw over 700,000 Georgians newly enroll in that 100 to 138% of the federal poverty level.
Right.
And those folks would get to keep their private health care insurance
Good.
under Peach Care Plus.
So what I'm afraid is we know these waiver processes, for crying out loud, it's taken, us 3 or 4 years already on the one that the Georgia Pathways. Well, if we sort of cut off support for that and then start the process all over again from this one, I don't see how that's moving the ball fast. And you guys all know more about that process than I do.
Yeah, I think so. What we're focused on is that fiscal impact. And so I think what we're missing out on is that influx in additional federal dollars, that $1.2 billion signing bonus, and all the ways in which that could increase jobs.
Stan, come talk. You were raising your hand. You're not signed up, but you're driving me crazy. So sit up here and tell us what you got to say.
Lots
Next
of
time,
lobbying
sign
tools
up.
in the bucket. So I just want to add one fiscal note to this. Some of it's been implied in some of the things that have already been said. Some of you may know I've spent my volunteer career around the mental health issue, served on several state commissions and one federal one. And one thing that doesn't quite get said out loud is that our financing of our mental health services is premised on serving the indigent who have no other insurance. And so one thing you are doing right now already is you're paying 100% of the cost of community mental health services, including the inpatient crisis stabilization units, the walk-in overnight units. So some of that can be financed if you will raise the percentage of people eligible for Medicaid expansion, most of whom are adults and primarily men, and women over the childbearing ages. So we are already paying 100% of the cost of our mental health services that would be part of the benefit package, and particularly under our private insurance program, and has a better benefit package than Medicaid alone. So you actually have some other resources to use after the first 2 years of the bonus. The Pathways waiver, I think, expires next year. So most of the fiscal issues are going to be part of the discussion in the amended and the 26 budget. But you already have state dollars to help pay for this going forward for about 30 to 40% of the people who are in the eligible category. And the last thing I like to say it this way, it's been not quite been said this way, but every Medicaid dollar goes to a provider. There's some management cost, it's pretty small, but when you talk about the money, it goes to people who are in the healthcare system already and helps preserve your hospitals. It backfills bad debt or indigent care, whatever we want to call it, and it raises up the financial strength of our hospitals and our physicians and our other types of providers. So I just wanted to add the mental health discussion to the thought process of whether we can afford this. Yes, you can. And mental health is very good politics for both parties. That's one of the things we've watched here over the last couple of years, and it's pretty exciting. And you support some things now like APEX, to get a counselor into the schools for the kids so that more of those kids can be paid for to see a counselor. That's part of the Medicaid expansion discussion. It's part of the general Medicaid discussion as well. So I think doing something now, you
Are
actually
you
have.
filibustering the bill? Because we got conference committees at 11 a.m.
That's
It's
all I got.
10:58. Anybody else want to speak on the bill? Senator Jones, Minority Whip, I see you here and you got your notepad. That's always scary. Do you, would you like to be heard, or would you save it for another day? All right. Obviously, thank you for being here, and the other senators that I see present in the room. Okay, the bill is before us. There's no further testimony. Senator Lucas, any closing remarks you'd like to make without revealing private conversations?
Finally, I like to say to all of us, your zip code ought not to matter about your health care. And that's what's happening in Georgia. Tree farms are in rural Georgia. Hog farms are in rural Georgia. Cattle farms are in rural Georgia. People choose to live where they want to live. But they ought to be able to get health care. And what you find out, those in rural Georgia, they have home remedies that they try to use when they get sick. So when they're in the emergency room, they are really sick. And that is the most expensive health care that we have. We got a couple rural hospitals are operating on 45 days cash, which means they might close when we get out of session. This helps pay for that uncompensated cost that these hospitals are going through. And of course, the big guys, they come out good too. But rural hospitals are scuffling. So, ladies and gentlemen, what I say to you today, we are making a link sausage. We mixing it up. And what we have to do is put the wrapping on the sausage that we mixing. And with that, Mr. Chairman, I have no more remarks. I think I've talked to everybody in here about this and word the H-E-double-L out of you about it.
I've had many conversations with you I won't reveal the details of, but you have been assured that you would have a day to explore this, to have a full, thorough discussion on it, and that's what we've been doing this morning. This has been an ongoing conversation for many years in Georgia, and I will say many years ago, I hate to think how many years ago, I admit how long I've been here, maybe overstayed my welcome, but when Obamacare passed, I was absolutely convinced that that was unconstitutional. I just didn't see how you could force people to buy insurance or buy any product or whatever. I knew the goal, and I knew the goal was good because we had too many people that were uninsured, and we needed to get them in a position where they could afford health care for their benefit and the health system's structure's benefit. So I asked to be placed on the health committee for the first time, and Athens Regional Hospital, which is now Piedmont in Athens, probably has 5,000 employees. So, and as most of us have hospitals that have a large number of employees in our districts and provide vital health care services to our citizens. I wanted to be in the conversation because I was 100% convinced there was no way that law would be upheld. But we were still going to have the problem. And we were going to have to find a Georgia solution, and I wanted to be at the table when that was done. So I spent about, I don't know, Senator Watson, 5 or 6 years on your committee. It wasn't even always yours, and I learned a whole lot more about scope of practice squabbles than I did about, health care expansion, and of course Obamacare was upheld. Well, we've been still dealing with the same problems. The CON is an element of the problem in our opinion, and it's worthy of a healthy discussion, but I am sort of personally in the position that Governor Kemp has taken a very strong lead on being creative, cutting-edge solution to use private health care by the waiver process, and I feel like I would like, I mean, everybody says the Georgia Access piece of his plan is fabulous. I think it's a nationwide model now, or should be, and I feel like we may be rushing the gun here to undercut his efforts to secure the waivers. And Senator Watson, you know the numbers of them, the sections and all that better than I do. I got the concept, but anyways, I do think we're all working the same direction to expand health care. And I want to keep working on this as we get there, and I am going to permit a vote on this today if it's the will of the committee. So we're at that point now. If anybody would like to make a motion, now is the time to make it.
Sir, I just want
Senator Rhett, you're recognized for a comment.
I just
Unless
wanted
you're
to.
making a motion.
I'm going to do that. I can do that
You
too.
might have a senior member in your delegation that might prefer to do that.
No, I'll allow him to do it. I just mainly want to thank you for this opportunity to bring us all together in dialogue over something that's important to all of us in our district, which is health care. Whether it's through the governor's program, lieutenant governor's suggestion, Peach Care, Medicaid expansion, we all want to see that our Georgians have the best health or access to the good health care. And I just want to thank you for allowing us an opportunity to dialogue on that. And I'll turn this over to the person by the initials DL with your permission.
Yeah, I don't want to, quell the conversation on it in any way. I think it's all very healthy, and I believe that the CON bill that we have passed, that hopefully will be resolved here in the next few days, by setting up that commission, keeps this dialogue moving, while at the same time giving the Pathways Plan a chance to either be approved or officially rejected. Majority Leader, I think I saw your light on over here.
Yeah, I'd like to make a comment and then make a motion. There's been a lot of discussion this year on health care. Like every year, we've had this discussion.
Make it anonymous.
Senator Lucas, you have been very passionate with your opinions on this issue. It's shown year after year. There's no question where your heart is, and I think everybody in this building wants to provide the best health care that we can afford. And I think that's the attempt that we have put forth for years now. But just looking at what we have currently, Georgia Access has been, I think, a huge success under the leadership of our governor. We have over 1,300,000 people that are enrolled on that plan. We fear losing the progress that's been made by switching and going a different direction will have a negative impact. We heard earlier by your estimate, we have no idea what the impact of this would be to our state budget. At least $500 million. That will continue to rise. We have no way to know if that number is high, low, or somewhere in the middle. We have a lot of issues there that we would have to open up and look into. We're right in the middle of reforming CON, Certificate of Need, has a lot of people in this room concerned. Every hospital in this state has reached out to us this year and last year. We're literally within hours of possibly agreeing with the House on a bill that will totally change the CON process in our state, which is hopefully for the good for all Georgians. We're in the middle of extending the hospital bed tax this year. We've already passed that out of the Senate, I believe. And then you come and you want to completely change this plan and talk about a full-blown Medicaid expansion plan. Now you're talking about maybe a modification, and you're calling it Peach Plus. A lot of issues in the air, a lot of questions that haven't been answered yet today that, quite frankly, I'm not sure anybody in this committee fully knows what the answers are. There's a lot to be to answer before we can move forward with this. So I would vote no on moving this bill forward. But I just want you to know I appreciate your efforts and I appreciate your passion for what you're doing here today. But I would be against this bill if there is a motion to go forward with it.
Senator, let me say this. Pathways is good. It has a work component with it. And the premiums are not the lowest, period. I'm trying to deal as a legislator, all of Georgia, and what I've seen in my 49 years serving up here, there is a gap. And people are not being served. North Carolina passed it, and they had 300,000 to sign up. Pathways got about 2,900. Affordable Care Act has about 730,000. And we've got that gap. Folks need to be served. That's the only thing I'm saying. And the only somebody can do it is us. Is us. We have to make that decision as to which way and which direction. Now, I introduced my bill. I served 37 years in the House. I know all revenue bills by the Constitution have to start in the House. But the discussion on Medicaid expansion had not reached the Senate. There has not been a discussion between the House and the Senate on Medicaid expansion that would affect all of Georgia. When you ask for a fiscal note, probably get it, but all revenue measures have to start in the House by the Constitution. But I'm telling you, $580 million, around that range. But you got $1.2 billion sitting in D.C. just for you to do it. And what I tell all of you, it's about the money. This is about money, gentlemen. This is all this is about money. That's all. You can look at it any kind of way you want it, but it's all about the money. The money we get versus what our expenses are to start up, and the folks that will be working. We will cover a lot of gaps that we've not been able to cover. And basically, we keep these rural hospitals open. To me now, they are the lifeblood of rural Georgia. And if we have another pandemic, we don't need for them to be closed. We need to get the help and the health care we need in our rural communities. And with that, I've said all I need.
Senator, I want to thank you for advancing the discussion, for your passion, for your heart, and your knowledge of this legislative process. I know this is important to you, particularly the rural areas, and that's why I've given you your forum here. What I'm hearing you say is that you don't have a fiscal note and you recognize that this should appropriately begin in the House, but since they didn't start it, you wanted to weigh in and have your say and hopefully keep this conversation going either through the conference committee on the CON bill that already has a component of a further study, or through other legislation that may come across from the House. Am I reading you right, my senator and friend?
Mr. Chairman, you read me right, but I need y'all support to pass this and get it on the Senate floor, have a vote, send it to the House, and then we will have a discussion between the House and the Senate about what it costs, what kind of program we gonna use, and how we gonna do it.
Okay. So you think we should consider a bill that's beyond our constitutional authority? It is a revenue bill, right?
Well, you know, if we send it over there, of course, they gonna talk about that.
You got them talking right now.
But the discussion between the House and the Senate about this important matter will take place. And I believe that in the wisdom of legislators, that somehow they will find the courage to do it, and we can start solving a lot of our health problems, mental ill problems in this state.
Right.
But it takes money.
So
And again, I said to you, it's all about the money.
Understood. The House CON reform bill contains a Medicaid component on the study commission. Do you think the proper venue for this continued discussion is in agree, disagree process, conference committee process on that vehicle?
Well, you know, the discussion hadn't started about it. The House, in its wisdom, kicked the can down the road. I don't know how long that 1.2 billion is going to sit there in Washington, and all these other states are doing it. And you look over there, it's 1.2 billion for Georgia, and they hadn't taken advantage of it. I would go after that to help my state, who's expanded Medicaid. I mean, it's just simple. I mean, we do it all the time. We give departments plenty of money, and they don't spend it, we take it back and spend it somewhere else.
Senator Harbison, Dean of the Senate, my
Yes.
sweet mate, you are recognized.
Thank you, sir. Just from some clarification, it has been alluded to about the fiscal note, which I understand you can obtain any time. You can get that. But I don't get the connection with the tax aspect of it cannot originate in the Senate because similar bills have, such as the CON. So I think that's probably incorrect.
That was Senator Lucas's comment.
Yeah, I think that's incorrect.
Right. What's the will of the committee? Oh, I'm sorry, Senator Anderson, I failed.
So I have a question because we keep talking about the governor's plan. Where are the numbers with that? Like, how successful has it been? I mean, real numbers.
I'm not certain, but Senator Watson knows better now. I'm going to recognize him to speak. My understanding of procedurally is that he had the Pathways program, obtained a waiver, and then it was reneged on, and now that's being appealed. And I might not be totally accurate where we are, and he's waiting to see if we can get approval to continue with that waiver. This would be another waiver that's, let's just say, more aggressive. Senator Watson,
And it
can
would
you
be
help me?
attached to the 1.2 billion. This waiver.
That's federal funding.
Right,
that
the
I'm
federal
not so
funding
sure
that
of.
wasn't
Yeah.
attached to the first waiver.
Hopefully it can be on his renewed. Senator Watson, can you educate us better so I don't
Sure.
say anything incorrect?
Thank you, Mr. Chairman. I mean, it is true. Remember, we did the waivers here. The waivers actually started here in this room, and I was chair. Actually, it was the first bill that we did when I was chair of HHS. And the 1332 waiver is what's now called access, and that's 100% to 139%. It is the national exchange. Next year, it will be the state exchange of which the ACA encourages, right? So California and a few other states, conservative and liberal, do that exchange. Next year, it will be, remember we passed the bill to get the fee, I think it's 3%. So right now, the federal government is paying all of those 730,000 people that are new enrollees from 100 to 138%. So 97% this year, state exchange will get that fee, and it will be 100% funded by the federal government. It's not a 90-10 split. It's not a FMAT split, which is usually 65-35. What we are struggling with is because of the public health emergency. It is the public health emergency that delayed redetermination of patients on Medicaid, and I'll call them patients. I'm a physician, right? So every year, a Medicaid patient has to re-up, fill out the information, and do that, see if they're still qualifying. So we got delayed by 3 years, and we have some time to do that. It will not finish, including the curing and the appeals, till probably around September 1 into the summer. And because of the delay that was caused by approval by one administration, disapproval by another administration, losing terribly in the federal court, that delayed our implementation. We have appealed because we have to redetermine, to use a term that's not correct, by 5 years. Those are the numbers we estimate in 1 year, and Deloitte did this. through DCH, 50,000 will be enrolled at about 1 year and 85,000 at 2 years. That still leaves probably about 200,000 people that are uncovered in a state of 11 million people. I agree with you, we should have it covered. The Arkansas plan, which is a mature plan since about 2016, a state of 3 million people, has 200,000 people uncovered also. That is 6.6% of their population. 200,000 of our 11 million is about 2%, 2.2% of our population. So I think we need to give this a little more time. I think we need to let it mature a little bit. But I agree with you. My goal, and I think our goal here, is to have everybody in the state of Georgia covered.
Thank you for being at the table with us. You were invited to participate on an ex officio basis on this committee today, since this is such a vital, important issue to the state, and you chair our health committee. Senator Dolezal was also asked to participate as an ex officio member due to the fact that he chaired our CON study committee this summer. Senator Dolezal, do you have comments or insights to share with us?
Industries, right?
This is a Regulated Industries Committee.
I'm on your committee.
You're ex officio here, right?
Yeah, just generally.
Okay. Oh, I'm sorry. He's a full committee member. My bad.
I don't have anything to add. I think it's been a good discussion. I think we have a number of members need to get to other places, so I would move that I would ask that we go ahead and take some votes here.
Is there a motion? The Minority Leader, you're recognized.
Well, I was going to ask for a couple of things, make a comment. We keep bringing up the Pathways program, but there's been $26 million spent on the Pathways program, and it's only signed up 3,000 people. The other thing I was going to ask for is an ex officio letter for Dr. Watson. Thank you. And I also want to make a motion to pass.
We have a motion to pass and a second from Senator Anderson. Are there any proposed amendments? Senator Brass, you're recognized.
Thank you, Mr. Chairman. I've got a series of amendments. Would you like me to cover them?
Let's go one at a time.
One at a time? Okay. Okay, so First Amendment should be in everybody's folder, and it's on the workforce development language that we kind of borrowed from North Carolina. Simply, y'all can read it, but it's simply setting up a fund, and that fund will go to incentivize, motivate, and support individuals who participate in work-related activities or in volunteer experiences.
This document is titled AM 520040.
That is correct, Mr. Chairman.
Is there a second?
Second.
Second by Senator Anderson. Any discussion on this amendment to set up I guess the easiest thing to say is you're setting up a fund and requiring some work for anybody to participate in the program?
Yes, sir.
Any further discussion on that? All in favor, raise your hand. Cindy, pay close attention. All right, I'm counting 7. All opposed?
8.
8. Okay. All right, that passes. Any other proposed amendments?
I've got a second amendment, Mr. Chairman. I've got copies I can distribute out.
That would probably be helpful if you want to just pass them around, or Haley, you make it a system.
So this amendment comes based on a conversation, I won't say with who, but it was had this morning, that others were told that they wouldn't have to vote on CON without Medicaid expansion being involved. So Amendment 2 fully repeals CON.
I have a second from, was that Senator Alves? So you amend this bill, you amend this bill so that if this passes, it will also completely repeal the Certificate of Need program in the state of Georgia.
That is accurate.
Discussion on this. All in favor, raise your hand. 1, 2, 3, 4, 5. Got 5. All opposed?
Oh, man.
That amendment fails.
Okay.
Further amendments, you're in order this time.
Folks just showed their hand. Okay, Amendment 3, based on your concerns, Mr. Chairman, and Chairman Watson, with his great wisdom in all this, Amendment 3, and I had to handwrite this one, but basically I want to say that this act shall be effective upon the expiration of the Pathways waiver.
Okay.
I think that will give it the, number one, it'll give time for the approval process should this bill pass. I think it gives the state the time it needs to get set up administratively to operate this program. And then as we've heard and from concerns, I think it gives Pathways the time it deserves to see if it actually works. And so
Is there
that
a
was.
second?
Excuse me, and thank you, Mr. Chair.
Hold on, you're,
Oh, okay, sorry.
you're not recognized
Okay.
yet. We got a proposed amendment. We would need a second before we had discussion. Is there a second to that amendment? I second it. Okay, any discussion? Would you like to speak now, Russ?
Yes, thank you, Mr. Chair. Line 73 to 74.
Hang on one second. We got a point of order by
This isn't the
Senator
rest of the committee. Only senators should be speaking at this time. This is in the rest of the committee. This should be senators speaking at this time.
I think your point is noted. Sorry, Ross. Want to pass that to a senator? You can.
I'll take it, Mr. Chairman. I see what you're saying. Actually, lines 73 and 74, the waiver provided for in this code section shall take effect upon the expiration of the current waiver. So actually, that language is in there. I retract Amendment 3.
All right, that's withdrawn. Are there any further amendments you got over there?
I got one last one, Mr. Chairman.
All right. what is there?
I guess now this will be Amendment 3. It was going to be 4. This is doing away with non-competes that hospitals and hospital systems have with our physicians and nurses and other healthcare staff. And this was part of some CON stuff and negotiations and other stuff. So I was adding it here as well, and I'll pass that out as well.
Okay, thank you. Is there a second, or does anybody need to see that first?
Yeah, sorry. Get a lot faster.
Madam Leader, you're recognized.
Oh,
Got a second from Senator Albert, so this is available for discussion once you all receive it.
he withdrew it.
Did you have a comment, Madam Leader? You're just waiting to see your copy.
The
You was-
other amendment, you withdrew one.
Number 3 was withdrawn. This is being called Amendment 4 here. Applies to Section 4B. Would you like to explain it in any more detail?
Yeah, sure. I mean, there's, during current practice, doctors and nurses and healthcare providers in general often have to sign non-competes. And so if, let's say you've got a doctor at a hospital or at a ambulatory surgery center in their hometown, they have to sign these non-competes, and a lot of times it's might have a 50-mile radius that they can't go practice what they train to do in that area, and they can't do that. Essentially, they can't practice in their hometown should they leave their current facility. And we're talking about healthcare providers, we're not talking about,
Well, you want to talk about lawyers? We have this in our canons of ethics and disciplinary rules. They are prohibited. You cannot impose a restrictive covenant on an attorney's employment rights.
Yes.
All right. What's the pleasure of the committee on that amendment? I'm going to call this Amendment 4 so our records will be clear. All in favor, raise your hand. And any opposed?
I hope you get votes.
Got 3 opposed.
One more vote.
Okay, that amendment passes. All right, any further amendments proposed?
Needed that CON to get
All right,
one more vote.
at this time then, before us is the bill itself as amended, so we're working on HB 1077, that's LC 5205557S, as amended by Senator Brass's 3 amendments. Any discussion on this committee substitute as amended? All in favor, raise your hand.
As amended.
No, the underlying bill as amended.
Six. You got 7 yeses, all opposed? I'm going to vote opposed to give this Pathways program time. It's a tie. The bill does not pass the committee. We will continue the discussion. Commit to you to do that as we go through this process. Senator Anderson, you got a question?
No, that's okay.
We are adjourned.